I'm Dr. Robert Jones, and in this lecture we're going to cover foreign body localization. So the focus question here is, does this patient have a foreign body? It's important to remember that missed foreign bodies are a leading cause of malpractice. Foreign bodies such as plastic, wood, and thorns are not visualized in plain radiographs and are easy to miss clinically. Ultrasound, fortunately, is an excellent imaging modality for both the localization and retrieval of foreign bodies. Looking at the literature, ultrasound is 83% sensitive and 59% specific for foreign body localization. It's 93% sensitive for wood foreign body localization, and it's about 73% sensitive for plastic foreign body localization. It's important to remember that these studies were done with radiologists who were highly trained in soft tissue ultrasound. So you have to keep that in mind when you're first learning this, that your sensitivity and specificity may not be the same as what's been found in these studies. Let's look at the bottom line here. Ultrasound is highly user dependent, and even in the most skilled hands, it's not going to be 100% sensitive, so you need to keep that in mind. Looking at the sonographic technique, you want to do meticulous scanning technique when looking for foreign bodies. You want to use the highest frequency possible, and you're going to use the linear transducer. You're going to use either liberal gel or a standoff pad if you're concerned for a relatively superficial foreign body. For potential foreign bodies of the hand or foot, you can use a water bath technique. Now, some of the sonographic findings may vary, but generally wood is going to be hyperechoic with acoustical shadowing. Here is a chicken leg with different types of foreign bodies within it. Here you've got the wood. It's hyperechoic, and you can see some posterior acoustical shadowing. Now, metal and glass will be hyperechoic. Here you really don't appreciate the hyperechoic foreign body, but you can see some degree of posterior shadowing here. Plastic is going to be relatively hyperechoic, and you can see a hyperechoic line here, and there's going to be a variable degree of shadowing. How do you miss a foreign body? Well, it's pretty easy, actually. If you look at the soft tissue here, there's multiple hyperechoic areas. You're also going to run into areas of shadowing, so it's actually very easy to miss a foreign body within the soft tissue. In foreign bodies with infections, you're going to frequently see a halo around there. This can make visualization of the foreign body easier. This is a sagittal view of the tip of the finger, and you can see in the volar pad there's this echogenic foreign body with a halo around it. This was a patient that had a retained wood foreign body. Here's a sagittal view of the thumb on the volar aspect, and here you can see the tendon sheath, or the tendon here, and here you can see a large amount of fluid within the sheath, and right here you've got the foreign body as the etiology for the inflammatory and or infectious response. Here's a patient that had a retained wood splinter, and you can see the very subtle posterior shadowing here, so this would be one that could be potentially easy to miss. Here's a transverse view of a patient with a relatively large wood splinter. You can see the echogenic foreign body here with the posterior shadowing. As we start moving closer to the insertion point, you can see the subcutaneous air, but this was a patient that had a very large wood splinter, as documented here on the ultrasound, and we were able to remove this under ultrasound guidance. Here's a patient that had a retained wood splinter, and you can see the very subtle posterior shadowing here, so this would be one that could be potentially easy to miss. Here's a patient with a metallic foreign body. This is up in the neck. This is posterior to their external jugular vein. This was an intravenous drug abuser who was trying to inject, and unfortunately the drug task force broke into the house as he was trying to do this. He missed the vein and broke the needle off. And here you can see a short axis view of the needle here, and you can see the posterior shadowing behind it. Here you can see a patient with a glass foreign body, you can see the echogenic foreign body and you can see the posterior reverberations here. This was a patient that had stepped on some broken glass, and here you can clearly see the foreign body. The echogenic appearance of the foreign body stands out more so than does the posterior reverberations. Here's another patient that has a retained glass foreign body. You can see the echogenic foreign body with some variable amount of posterior reverberations. You can also see some fluid surrounding the area here. Sometimes the inflammatory response makes it easier to detect these foreign bodies. We want to go over foreign body removal. While it intuitively may seem that under ultrasound guidance it should be very easy, foreign body removal, even with ultrasound guidance, can be very challenging. You've got to choose the foreign bodies that you're going to remove under ultrasound guidance very carefully, and in skilled hands you can remove these foreign bodies safely with smaller incisions, but some of the studies that were done in the radiology literature show that even in the hands of skilled operators early in the learning curve, it may take upwards of 60 minutes to remove these foreign bodies, and I can't think of any emergency physician that has 60 minutes of spare time to remove a foreign body, so you need to keep that in mind. Let's look at foreign body removal technique. You got to select the foreign body. You want to make sure that you can easily visualize the foreign body in a long axis plane. You're going to have good transducer control. For deeper foreign bodies, you want to use alligator forceps as opposed to hemostats. You can use a hydrodissection technique where you depot a liberal amount of lidocaine around the area to free it up from the soft tissue, and then you're going to gently remove the foreign body. Now remember, these can be difficult to remove. It's worth giving it a try if you have time, but if you've failed on several attempts, you may want to stop and have this done on an elective basis. And if there's an infection, you may want to have this done on a more urgent basis, but by a surgeon in a more controlled setting in the OR. Here's an example of wood foreign body removal. This was a patient that had a wood splinter in the volar pad of the finger. We were able to make a very small incision, isolate where the foreign body was using a sagittal plane, grab it with a pair of alligator forceps, and gently remove the foreign body. Once the foreign body was removed, the cavity was irrigated, and this patient did well and required no further operative therapy. He was kept on Augmentin for 10 days, but did well. Now this concludes the Focused Soft Tissue Foreign Body Localization lecture. I'm Dr. Robert Jones, and in this lecture we're going to look at the sonographic findings of tenosynovitis. Causes of tenosynovitis include penetrating trauma, infections such as disseminated gonorrhea, as well as inflammatory causes. The most common infectious organisms include staph and strep. It's important to remember that ultrasound cannot distinguish between infectious and non-infectious causes. Sonographic findings of tenosynovitis include fluid present within the tendon sheath. Now the fluid can be either anechoic, hypoechoic, or hyperechoic. The affected tendon may be enlarged and show signs of a tendinosis. Color Doppler, if used, may show hyperemia, and if the cause was penetrating trauma, you may be able to detect foreign bodies also. Let's take a look at a case. We got a 32-year-old male, non-traumatic pain and swelling to his left wrist. He has a history of end-stage renal failure, on dialysis. He's afebrile, has a normal white blood cell count, CRP, and ESR. On ultrasound exam, you can see that this patient, on the sagittal view here, has a fluid collection surrounding his extensor tendons at the wrist. And you can see on the transverse view here that he's got a large fluid collection surrounding the extensor tendons on the wrist. And in certain areas, you can see that this fluid collection is echogenic. Even though this patient had a normal white blood cell count, CRP, and ESR, he had an echogenic fluid collection surrounding his extensor tendons, so the decision was made to perform an ultrasound-guided aspiration of that fluid collection. And this was done, and it turned out that this was all bloody fluid. Cultures were negative, and this patient did well with immobilization and ice, and in follow-up was asymptomatic a week and a half later. So this patient had a hemorrhagic tenosynovitis. Echogenic fluid within the tendon sheath can be caused by either hemorrhage or infectious causes. You can't tell the difference between the two with ultrasound. As you look at the other modules, I think you see this as a recurring theme, that echogenic fluid can either be caused by hemorrhage or pus. Here was a 24-year-old woman, came in, non-traumatic swelling of her right wrist and hand. Again, she was afebrile, had normal WBC count, ESR, and her CRP were also normal. But if you take a look, here's a sagittal view over her extensor tendons here. You can see that she's got this fluid collection, and it appears relatively anechoic. But because we were uncertain of the diagnosis at that point, we went ahead and performed an ultrasound-guided aspiration of the fluid collection. And here you can see the pre-drainage. Here's the needle on a sagittal long axis view within the tendon sheath. And here is the post-drainage after all the fluid has been removed. So this was both diagnostic as well as therapeutic. This patient was ultimately found to have disseminated gonorrhea. Actually, the DNA swab of her cervix came back positive for gonorrhea. She was treated with Rocephin and did well. The tenosynovitis associated with this occurs in approximately 68% of cases of disseminated gonorrhea, and most commonly it's going to involve the wrist and the hands, and these do respond very well to antibiotics, as happened in this case. And here you can see real-time the drainage of the fluid under ultrasound guidance. So here is the sagittal view, and you can see the fluid in the tendon sheath. Here you can see the long axis approach, the needle that's being brought in, and here you can see the needle tip, and here you can see the needle entering the fluid collection. And at this point now, drainage is going to occur, and we can remove the infected fluid, and this is both diagnostic as well as therapeutic. So you can see that the fluid now is being removed, and at the end of the drainage, it's essentially gone. Here's a patient that came in with swelling and limited range of motion of their thumb. They thought that a wood splinter had broken off several days ago, but they weren't certain. When we went ahead and scanned the patient, you could see that here was the tendon here. You can see the bone here. You can see the joint here. And you can see that there's a fluid collection here surrounding the tendon. On the transverse view, you can see that there's a foreign body that's literally right under the surface of the skin that extends into the tendon sheath here, and that was the cause of the tenosynovitis and the inflammation. And you can see there's a tendon, or there's a foreign body that's extending in. You can see it starting right up in there. And you're seeing it best in the transverse plane right here. Here's another case of a patient who has pain over the dorsal or radial aspect of the hand, particularly over by the thumb. Patient denies any genitourinary symptoms and was ultimately tested to be negative for gonorrhea. Had no puncture wounds, no cat bites, no human bites. Does a lot of heavy lifting as a laborer with his right hand. You could see that in the area of the snuff box, he's got a large amount of fluid surrounding the tendon here. And you can see here on transverse scanning that the patient has a fluid collection around the snuff box tendons here. And you can also see that on the sagittal view. The fluid appears to be relatively anechoic. The etiology of this fluid collection was unknown. There was no evidence of puncture wound or trauma to explain it. His gonorrhea testing came back negative, but because of his degree of symptoms, this patient underwent ultrasound-guided aspiration. There were approximately 22,000 white cells. The culture came back negative, and with immobilization, this patient did well, and it was felt to be related to his excessive use during work as a laborer. Here's a 45-year-old male who was accidentally bit by his cat to the medial aspect of his right ankle. Patient came in complaining of severe pain along the medial aspect of the ankle by the posterior tibial tendon and had decreased range of motion. If you look at a sagittal view over the posterior tibial tendon here, you can see that there's a very large fluid collection here, and you can also see that on the transverse view that there's a very large fluid collection that is localized but is surrounding the tendon, and this patient has evidence of infectious tenosynovitis. This patient was taken to the OR. Here's a patient who clinically fit more of a cellulitis. However, during ultrasound examination, you could see adjacent to his flexor tendon that there was a very, very small amount of fluid here. So he had a very, very early sonographic finding of tenosynovitis. This patient still was treated with IV antibiotics, elevation, immobilization, and warm compresses and did well. This now concludes the tenosynovitis lecture. I'm Dr. Robert Jones, and in this lecture we're going to go over clinical applications of the focused soft tissue examination. In the diagnosis of cellulitis, ultrasound has a limited role here. The cobblestoning seen with cellulitis is a nonspecific finding and cannot be used to rule in or rule out the diagnosis of cellulitis. With subcutaneous abscesses, ultrasound is highly sensitive for the detection of subcutaneous abscess cavities. It's important to make sure that you see that the cavities are confined to the subcutaneous tissue. Make sure that you can see the base of the cavity. In high-risk areas, make sure that the internal contents will swirl with compression. If you're in an area where there may be other glands, such as lymph nodes or salivary glands, the use of Doppler may be helpful. Ultrasound may be helpful in detecting high-risk findings of a soft tissue infection, such as the presence of air within the cavity or air within the soft tissue or fascial thickness or deeper fluid collections, but the diagnosis of these more serious soft tissue infections should not be excluded with ultrasound if the findings are not detected. Misformed bodies are a source of great liability for the emergency physician. Ultrasound is a great tool since it's highly sensitive for the detection of foreign bodies, including those foreign bodies that will not be detected with plain radiographs. However, the detection of these foreign bodies is extremely operator dependent, and this needs to be kept in mind, especially with the beginning scanner. In a patient who you highly suspect has a foreign body, failure to detect it with ultrasound should not sway you from the diagnosis, and this would be a patient that maybe you would consider obtaining further imaging in. Also, it's important to remember while ultrasound is great for the detection of foreign bodies, and it's even helpful in ultrasound with ultrasound-guided removal, ultrasound-guided removal requires a greater deal of operator skill, and this may not be practical to the emergency physician in a busy emergency department. Ultrasound is highly sensitive for the detection of fluid collections within the tendon sheath. So when you're scanning hands and feet for soft tissue infections, it's not uncommon that you'll come across evidence of a tenosynovitis. It's important to remember that ultrasound will not differentiate between infectious and non-infectious causes of the tenosynovitis. Ultrasound can also be helpful in aiding with ultrasound-guided drainage of these fluid collections. This concludes the soft tissue clinical applications video.